Okay, so do any of you remember this case in 2013? A law student in Colombo University lost her hand. It was told to be due to medical negligence. Can you remember? I think you might have been very young then. So anyway, in 2013, this young girl lost her hand due to the negligence of doctors. So at the end of this lecture, you will understand what happened to her and you can act to prevent such things happening. Okay. So the lecture today is on the forearm. The objectives are to describe the muscle groups, compartments, their attachments and their actions, and to describe the nerves, blood vessels of the region, and to explain the anatomical basis of common clinical conditions. So if we quickly revise the osteology, what are the bones of the forearm? Can someone tell me? So you can see here, what are the bones? Radius and ulnar. Yes, the ulna and the radius. So more medially you have the ulna. You have the trochlear notch here. It's not very obvious, but I think you have done your osteology. So you have the olecranon process going behind the humerus, and then you have the coronoid process. You have the shaft and the head, and on the radius you have the head here, the small neck, the shaft, and the distal end. And between these two bones, you have a membrane attached to the these internal borders. It's called the interosseous membrane. So osseous means bone, right? Between the bone. So it's called the interosseous membrane. Then at the proximal end of the forearm, you have the elbow joint. It's made up of three bones, the humerus and the two bones of the forearm, the radius and the ulna. So on the humerus, the capitulum here articulates with the radial head here. And more medially, you have the trochlea articulating with the trochlear notch of the ulna. It's a synovial hinge joint. It's called synovial because it's covered with the capsule and it's lined with the membrane, the hyaline membrane, and it's filled with fluid called hyaline fluid. And if you take the action of the joint, you can call it a hinge joint. Hinge means how a door is connected to its frame. Right? So this is a hinge. In Sinhala, you call it tasawwa. I don't know the Tamil word. So in Sinhala, you call it tasav sandhya. It's because its action is like a hinge. You can flex and extend it. Then at the distal end, you have the wrist joint. The wrist joint is formed by the radius, the distal end of the radius, and the scaphoid, lunate, and triquetrum. These are bones of the carpus. Bones, small bones found in the wrist. These three bones, and you have an articular disc. It's made out of fibrous and cartilage tissue, and it separates the ulna from the wrist joint. So the ulna bone is not involved in the wrist joint. It's also a synovial joint, and it's an ellipsoid joint. It's like an ellipse. Then you have the proximal and the distal radioulnar joints. So proximally, you have the proximal radioulnar joint, and it involves the head of the radius here, and it's surrounded by the annular ligament. This is the annular ligament, and it's joined on the either side of the radial notch of the ulna. This is the radial notch of the ulna. And the head of the radius can move freely within this ligament. It can rotate. So it's a synovial joint again, and it's a pivot joint because it can rotate. Then you have the distal radioulnar joint. The distal aspect of these two bones. It involves the rounded head of the ulna and the ulnar notch of the radius. Yeah. It's again a synovial pivot joint. Now we come to the osteofascial compartments. So when you take the forearm, all the contents are covered by a fascia. This is the subcutaneous fascia. So you have the skin, the subcutaneous tissue, and then you have this fascia. This fascia is attached to the subcutaneous border of the ulna. This is the ulna. This is the radius. If you feel along your medial aspect of the forearm, you might feel your bone. That's the subcutaneous border of the ulna. Right? So this is the medial side, right? So if you feel along this side, you can feel the bone. So that's the subcutaneous border of the ulna. So this fascia is attached to it at that side, and it surrounds all the muscles, nerves, and the arteries and the veins of the forearm. And again, within this compartment, there are subdivisions. So between these two bones, you have the interosseous membrane you saw earlier. So this divides the forearm into anterior and posterior compartments. These compartments are again, they can again be divided into subcompartments by intermuscular fascia. There are layers of fascia between the muscles. So these can divide these compartments into superficial group, intermediate group, and deep group, like that. And you have the posterior compartment here. And in the posterior compartment, some textbooks consider a lateral compartment. So on the lateral aspect, you have a lateral compartment. And then on the posterior aspect, you have the posterior compartment. This posterior compartment can again be divided into deep and superficial compartments. And each of these compartments have nerves and blood vessels. So here this diagram shows the compartments in different colors. Right? So here you can see the anterior compartment. Here this is the median nerve, then the ulnar nerve and artery. We look at them later on, the blood supply and the nerve supply. Right? So these are the anterior interosseous nerves and vessels, the posterior interosseous nerve and vessels, and the radial artery and the nerve. So these are the different compartments of the forearm. And then if you look at the anterior compartment, they are involved in flexion of the wrist and the fingers. So although these muscles arise in the forearm, they get inserted into the wrist, the carpal bones, the metacarpals, and the phalanges. So do you know the bones of the hand? Have you completed the osteology? Can someone answer me? Do you know roughly about the bones of the hand?
Yes, madam, we had a lecture on bones.
Okay, then that's fine, right? So these muscles can get inserted into the bones of the hand. Okay, so these flexor compartment muscles, most of them originate from the medial epicondyle of the humerus, right? So it's called the common tendon of origin. And another point to remember is that the flexor compartment muscles are more powerful and bulkier than the extensors. It helps in making a fist and holding something tightly. Right? So if we look at the different muscles, here we have the superficial muscles, the intermediate muscles, and the deep muscles. Right? So most superficially, you have 4 muscles: the pronator teres. All these 4 muscles arise from the medial epicondyle of the humerus here. Right? So this pronator teres has 2 heads, and one is from the medial epicondyle, another is from the olecranon, as I remember. So it gets inserted into the radius, and then you have the flexor carpi radialis. It gets inserted into the radial aspect of the hand, specifically to the second metacarpal, to the bases of the second and third metacarpal bones. And then you have the palmaris longus. It attaches to this sheath, palmar sheath. Like it doesn't attach to a specific bone. It attaches to this sheath in the palmar aspect. And this muscle doesn't have a lot of, doesn't have a major function, and it can be absent in many. Right? You can't find it in everyone. Then you have the flexor carpi ulnaris. The origin is the same, and it gets inserted into the lateral aspect of the hand, 5th metacarpal bone. Then in the intermediate layer, you have the flexor digitorum superficialis. It has an extensive origin like this, right? From the it also has origin from the medial epicondyle of the humerus and the olecranon, and it has origin from the anterior aspect of the radius like this, and it gets inserted into the middle phalanx, right? To the middle phalanx of the hand. So if you take the carpal bones like this, the carpals and the phalanges, this gets attached to this phalanx, right? So it has 2 tendons. It divides into 2 and attaches to either side of these middle phalanges. So then when you look at the deep muscles, you have 3. You have the flexor digitorum profundus. It rises from the this medial aspect of the forearm, from the ulna and from the interosseous space membrane like this, and it gets inserted, these fibers gets inserted into the distal phalanx. It was more internal to these fibers of the flexor digitorum superficialis and gets inserted into the distal phalanx. You can look at diagrams and understand it, right? So it goes and inserts into the distal phalanx. Then you have the flexor pollicis longus. So pollicis means the thumb, right? And longus means long. So it gets attached, it arises from the lateral aspect of the forearm and it gets inserted into the distal phalanx of the thumb, right? Then more anteriorly, you have the pronator quadratus, which is found between the anterior aspects of the ulna and the radius. So these are the muscles. So you can go through them slowly, and you can look at images in your atlases and textbooks and understand their attachments. Right? Then you have the lateral and the posterior compartment or the extensor compartment. These muscles, also most of them, actually the superficial muscles, have a common extensor origin, like the flexors. These are attached to the lateral epicondyle. It's prominence on the lateral side of the humerus, the lower end, right? So these are the muscles of the lateral and the posterior compartment. So some textbooks consider lateral compartment and posterior compartment separately, and some consider them commonly as one posterior compartment. So the lateral compartment is considered as these two muscles, the brachioradialis and the extensor carpi radialis longus, this muscle, right? So these two muscles some consider separately. Something to remember is that although the brachioradialis is considered in the lateral or the posterior compartment, it's a flexor of the wrist. It's a flexor, right? So when the arm is semi-pronated. So do you know what pronation and supination are? Okay, so I hope everyone knows. So when the hand is half pronated, means semi-pronated, flexion of the the flexion of the elbow, right? Flexion of the elbow joint is mainly by this brachioradialis muscle. Then you have the extensor carpi radialis longus muscle. These two muscles originate a little above. There's a ridge on the humerus. I hope you all remember from osteology. On the humerus, you have above the epicondyle. So you have a small ridge, right? This area. So this is the lateral epicondyle. This is the medial epicondyle. So these two muscles arises more superiorly to the lateral epicondyle on the supracondylar ridge. And then you have the extensor carpi radialis brevis. This also, so this extensor carpi radialis longus and brevis, they also get attached to the bones of the hand, to the lateral aspect of the hand, actually to the metacarpus. So the flexor carpi radialis inserted into the lateral to, the second and third metacarpal bases on the flexor aspect or the palm aspect, right? So these get attached to the dorsal aspect of the same two bones. Then I'm not sure if I'm very clear, but anyway, you can look at the images and study them slowly. You have to slowly grasp, right? And then the extensor digitorum, it also arises from the lateral epicondyle, and it gets inserted to the extensor expansion of the fingers. Extensor expansions are found on the posterior aspect, the dorsal aspect of the fingers. Right? So extensor digiti minimi is the same. So digiti minimi means the small finger. Right? So this gets attached to the extensor expansion of the small finger. Then you have the extensor carpi ulnaris. It gets attached to the base of the fifth metacarpal bone. Then you have the anconius, which is a small muscle involved here. It gets attached to the ulnar bone. So these are the superficial muscles of the extensor compartment. Then you have the deep muscles. Here you have again 5 muscles. Right? You have the supinator originating from the lateral epicondyle and the olecranon of the ulna, and it gets attached to the radius in the lateral aspect. Then you have the abductor pollicis longus, extensor pollicis longus, and extensor pollicis brevis. All these muscles are attached to the bones of the thumb. Then you have the extensor indicis muscle. It's involved in when you point at someone, that's the muscle you use. That's the extensor indicis, and these muscles, the deep muscles, the abductors and the extensors of the thumb and the extensor of the index finger, they arise from the posterior aspect of these bones and the interosseous membrane. In the specific attachments you can study slowly. So in case you're not clear, these show the actions of pronation and supination. So this is, the hand is facing upwards. So this is supination, right? So you have the word up in it, the palm facing up. So it's supination. And when you turn the hand downwards, it's pronation. So it occurs in an axis traveling through the head of the radius and the distal radioulnar joint along this line. The head of the radius moves freely within this annular ligament, and the distal part of the radius turns around the head of the ulna. So can you guess what are the muscles involved in pronation?
Pronator teres.
Yes. Another muscle? Another pronator? Pronator quadratus. So it's in the name itself, right? So nothing to study separately. Pronator quadratus and pronator teres. Then what about supination?
Supinator.
Yes. So that's also the same, right? The word itself tells what it does. So then we will look at a few special areas in the forearm. First, you have the cubital fossa. It's found in the anterior aspect of the elbow joint. So if you look at the boundaries, laterally you have the brachioradialis here. Right? So this is the brachioradialis. It's cut in the middle to show the internal structures. So you have the brachioradialis, and on the medial aspect you have the pronator teres. This is the pronator teres. Then it's bounded superiorly by an imaginary line passing between the two epicondyles of the humerus, the medial epicondyle and the lateral epicondyle. So this triangular area is called the cubital fossa. And on the floor, it lies on the brachialis muscle here. Posteriorly, you have the brachialis muscle here. And then inferiorly, you have the supinator muscle. So these form the floor. And the roof is formed by the skin and the underlying fascia. It's not shown here. And also the bicipital aponeurosis. This is the bicipital aponeurosis, right? When you consider the contents, when you come from medial to lateral, you have the median nerve here, then the brachial artery, tendon of the biceps, and the radial nerve. And in front of all these, you have, after being covered by the deep fascia, you have the veins, the medial cubital vein crossing this. We will look at the veins in a little bit, but for you to know now, it's a vein traveling on the anterior aspect of this cubital fossa. If you look at the clinical importance of these structures, when you check the blood pressure, you listen to the arterial blood flow at the brachial artery. So this is the point where you keep your stethoscope and listen to the blood flow. So it's just medial to the biceps tendon here, right? So you palpate the tendon and just medially you can feel the pulse. Now itself, if you can feel just medial to the biceps tendon, you can feel your pulse. So that's the point where you listen to the arterial blood flow. Right? Then I said that there's a vein traveling here on the anterior aspect of this cubital fossa. This is usually visible, and I think most of you know that the blood is usually taken from this vein because it's visible and easy to palpate. Then another important area is the anatomical snuff box. It's on the the lateral aspect of the wrist, right? It's actually in the hand, but involves the margins involves the tendons of muscles originating from the forearm. You have more medially the tendon of extensor pollicis longus, this one, and laterally you have the tendon of abductor pollicis longus and extensor pollicis brevis. So it forms this small triangular area. Okay? And if you palpate within it, you can feel the scaphoid bone. Right? So let's just show the video. Like I hope you can see here. If you extend your thumb, you can feel a small shallow area. Right? So this is the anatomical snuff box. You can even look at pictures, right? I'm not sure if you saw it correctly. It's called the snuff box because people used to keep tobacco powder in this area and sniff it. So that's why it's called the snuff box. And so I told you that the scaphoid bone can be palpated through it. So if there's a fracture, if you touch that area, it will be painful. That's what tenderness means, right? Pain on touching or pressing, right? And also the radial artery crosses this anatomical snuff box, and it can be palpated there. Then another important area is the carpal tunnel. The carpal tunnel is formed by the carpal bones and the flexor retinaculum. Here. So I hope you know about the carpal bones. And then you have the flexor retinaculum here, which is attached to the most medial and the lateral carpal bones. So medially you have the scaphoid and the trigetrum. Then laterally you have the pisiform and the hamate. So the flexor retinaculum is attached to these bones, and this flexor retinaculum along with the carpal bones forms a tunnel. It's covered by a fibrous sheath, and there are some structures traveling within it. The main structure you have to know about is the median nerve. You have the median nerve and some flexor tendons. You have the tendons of the superficial flexor digitorum and the flexor digitorum profundus, the deep flexors. And also you have flexor of the thumb, the long flex of the thumb, flexor pollicis longus. So the ulnar nerve and others travel outside this tunnel. Then a small activity for you to do at home. slowly go through the diagrams in the atlases, pictures from the internet and everything, and slowly fill this. This shows the compartments of the forearm and the muscles, the blood vessels and the nerves. And this contains each muscle. You can mention the compartment, their attachments and nerve supply, and also the nerve roots, the spinal level, the spinal root level, whether it's T1, T2, T3 like that. And then the action. You can actually work out the action from these attachments. So look at the attachments slowly and try to imagine what will happen when this muscle contracts. That is, it becomes short. So you can feel this at home, right? Then if you look at the arteries of the forearm, you have the brachial artery entering the forearm and it divides into two, right? You have the ulnar artery. So this is the brachial artery, ulnar artery and the radial artery. This radial artery travels in the lateral aspect of the forearm and the ulnar artery travels in the medial aspect. This ulnar artery gives a small branch. It's called the common interosseous. And this divides into two, the anterior interosseous and the posterior interosseous. The posterior interosseous travels behind the interosseous membrane and enters the posterior compartment of the forearm and travels downwards along the posterior surface of the interosseous membrane. And then the anterior interosseous artery travels along the anterior aspect of the interosseous membrane. So those are the main nerves of the forearm. If you look at the picture, you have the brachial artery, the ulnar artery, and the radial artery. From the ulnar artery, you have the common interosseous artery. Then you have the posterior interosseous artery, which travels behind the interosseous membrane and enters the posterior compartment. Then here you have the anterior interosseous artery, which travels in the anterior aspect of the interosseous membrane. It travels between these two muscles, the flexor digitorum profundus and the flexor pollicis longus. Right? So as the arteries enter the hand, you can study what happens in the hand later on when you do the hand. Then if you talk something important about the blood supply of the forearm, you can talk about the anastomosis. So in this elbow region, you have a anastomosis between the brachial artery and the profunda brachiae artery here. So do you know what an anastomosis is? Can someone tell me? Anything what you understand by the word anastomosis? I'm sure at least some of you know.
A branch that connects two arteries.
Yes, it's it provides alternative pathways, right? So here, when you take this anastomosis around the elbow joint from the brachial artery, you have very small branches connecting to the distal part. So if any area gets blocked due to a clot or damage, these alternative paths can provide blood supply to the distal areas. So if this artery gets blocked, the brachial artery gets blocked, the profunda brachial artery can provide blood supply the distal parts through this anastomosis. Now, in the elbow joint, you have the first you have the recurrent branches of the radial artery here, and the recurrent branches of the ulnar artery. Then you have some branches from the profunda brachii artery here. Then from the brachial artery more high above, you have the two branches, superior ulnar collateral and the inferior ulnar collateral. So these join together and provide alternate pathways for blood supply in case any of these get blocked. Then we come to the veins. When you come to the veins, you have two groups, the deep veins and the superficial veins. The deep veins, these are called venae comitatus. They follow the arteries. Usually on either side of the arteries, you can find these veins. They are usually double, right? Then you have the superficial veins. The superficial veins don't follow the arteries and they are found superficial. And on the medial aspect, you have the basilic artery here. It travels in the medial aspect like this, around the elbow region. And it joins the brachial artery, the brachial vein, and forms a axillary vein, which becomes the subclavian vein. And then on the lateral aspect, you have the cephalic vein. This is the cephalic vein. So it travels on the lateral aspect of the forearm, and it joins the axillary vein directly. So this is the median cubital vein we talked about in the cubital fossa. So it joins the basilic and the cephalic veins here. Then about the lymph drainage. So lymph is extracellular fluid, fluid that gets collected between cells. These superficial, lymph also you can consider a superficial and deep lymph. So the superficial lymphatics follow the superficial veins, the cephalic and the basilic veins. The deep lymphatics usually follow the arteries. In other organs as well, usually the deep lymphatics follow arteries. When you consider nodes, so collections of lymph. Okay? So here in the elbow region, you have the supratrochlear or the epitrochlear nodes. These drain into the lateral group of axillary lymph nodes. So I hope you know about the axillary lymph nodes, right? So then, these drain into the intraclavicular lymph nodes just below the clavicle, right? From the lateral aspect also, those which follow the cephalic vein, they drain into a node called the deltopectoral node, the deltopectoral groove, and they also drain into the intraclavicular lymph nodes. And then when we consider about the nerve supply, if we first look at the cutaneous nerve supply, you have nerves which supply the skin, right? Sensory nerve to the skin. You have the lateral cutaneous nerve of the forearm, which is a continuation of the muscular cutaneous nerve. And you have the posterior cutaneous nerve of the forearm coming from the radial nerve, and the medial cutaneous nerve of the forearm, which comes from the medial roots. I'm not sure, just check, right? So those are the superficial nerves of the forearm. Then you can also consider them as the dermatomes. So these are the nerve root levels the spinal levels which supply the skin. So if you take the upper limb, you have C4, C5, C6 on the thumb and the index finger. Then you have C7 for the middle finger, C8, the lateral two fingers, and in the medial aspect, you have T1 and T2. So by checking the sensation of these areas, we can see if there are any disease at the spinal level. When you consider the internal nerves of the forearm, you have three nerves. Okay? The median nerve, ulnar nerve, and the radial nerve. So the median nerve we have already seen, right? It enters the forearm within the tubular fossa. So it enters the forearm and travels between the two heads of the pronator teres and travels on the flexor digitorum profundus, right? And enters the carpal tunnel here. And on the medial side, you have the ulnar nerve behind the medial epicondyle. It enters the forearm and it travels between the two heads of the flexor carpi ulnaris and travels on the medial aspect of the forearm. And it has two branches to supply the skin, a dorsal branch here and a palmar branch here. Then you have the radial nerve, which travels on the lateral aspect. It enters the forearm anterior to the lateral epicondyle. So the ulnar nerve entered posterior to the medial epicondyle and the radial nerve enters anterior to the lateral epicondyle. It divides into two branches here. The deep branch, which travels through the supinator, and it becomes the posterior interosseous branch and supplies the muscles of the posterior compartment. And you have the superficial branch here, which travels on the lateral aspect of the forearm. You can read the textbooks and fill this chart slowly. Okay? The nerves, their spinal levels, the branches, the skin areas they supply, and the muscles they supply. Now we come to a clinical point. The compartment syndrome. So we learned that the forearm can be divided into compartments, and these compartments are closed areas, right? So if any damage occurs to them, if the soft tissues, the muscles, anything damages, like if a fracture occurs, the soft tissue within this compartment start to swell, right? So when this, So if we take one compartment, so if the muscles in this compartment are damaged from soft tissue, from blunt trauma or from a fracture, if a bone is broken here, it can damage the muscles here, right? Or from, if someone hits the forearm, there will be blunt trauma, so there will be swelling of the soft tissue. First, the veins will get compressed. So the veins have very thin walls. So what will happen first is the veins will get compressed, and this will impair the venous drainage first. And after that, only the arteries will get compressed because arteries have a thicker wall. So even when the veins are compressed, there will be collection of deoxygenated blood here. So the muscles and the structures will not get enough blood. So first, the sensory nerves are very small. So they will get ischemic. Ischemic is loss of blood supply, and it will not get enough oxygen, and it will start to die off, right? So there you will feel altered skin sensation, and there will be pressure on the nerves, on the main nerves, and this will result in a pain disproportionate to the injury. And when the muscles get ischemic, there will be pain on passive stretching of the muscles. If you take the hand of the patient and try to stretch it, it will cause pain. And there will be tenderness. Even when you touch the patient's skin over the forearm, it will be painful for them. And finally, if the arteries are compressed, it will prevent blood flow into the hands, and there will be absence of capillary refill in the nail beds. So capillary refill is checked by pressing the nails. If you just press your nail bed like this, you can see that it turns white. And if you let go, it should the color should return. The red color should return. So if it takes less than 2 seconds, it's normal. If it takes more than 2 seconds, it is abnormal. So that's what the absence of capillary refill means. So if you detect this in a patient, you have to quickly incise open the affected compartment. If there are any casts or surrounding bandages, you have to remove them and open the fascia. You have to cut open the fascia and release the pressure inside. Otherwise, even if there's a delay for around 4 hours, there will be damage to the muscles because of ischemia, because of lack of oxygen, and that damage can't be reversed. So that's what happened to this girl in 2013. Right? She had fallen on a staircase and damaged her forearm, and a cast was applied, and she was complaining of severe pain. Pain is just disproportionate to the injury she has had. So she was given very strong painkillers for the pain, but the cause was not looked into. And finally, she had irreversible damage to the forearm muscles, and her hand had to be removed from above elbow. So you can just imagine, right? Without the forearm and the hand, so this could have been prevented, right? So I hope now you understand what happened in this case, and you will be able to prevent such things happening in the future. We look at a few other important clinical conditions. You have the tennis elbow and the golfer's elbow. So the tennis elbow is also called lateral epicondyle, like this. You know the superficial extensors of the forearm. A lot of them got attached to this lateral epicondyle. If there is excessive movement of these muscles, such as in tennis players, and like working on the computer for long, and like violinists, I think, so they will this area, this common extensor tendon will get damaged. There will be small tears and all, and it will cause pain. So there will be pain on extension, and on touching that area, it will be painful. That is called the tennis elbow. So to treat it, you can, the main thing you have to do is to rest the muscles. And there are other methods also. You can give pain medication. You can give injections to that area to reduce the swelling. And if there are collections of like fibrous tissue, you can surgically remove them as well. Then, similar to the tennis elbow, you have the golfer's elbow that occurs when the common flexor tendon gets damaged. So the common flexors, so most of the flexors got attached to the medial epicondyle. Here. So if this common tendon gets damaged, like in golfers, they use these muscles extensively. So if these tendons get damaged, it will cause pain and reduce movement. Right? So the treatment is same. You have to rest the forearm, and you can take pain medications, and you can inject to reduce the inflammation and surgical debridement. Just understand what happens, right? So when there's extensive movement of these muscles, it will cause damage to the common flexor tendon and it will cause pain. So if we look at a summary, we talked a little bit about the osteology and joints, about the forearm compartments, the muscles, the blood supply and the lymph drainage, and also about the nerve supply. And finally, we looked at a few common clinical conditions. So at home, you can read on these following topics, right? No point of me just going through them in this lecture. You can slowly go. It will just be another set of words for you. So you can slowly go through these topics in a book. Right? So read about forearm fractures and the carpal tunnel syndrome. So these are the references I have used, and you can use them for your further reading. Thank you.